Thank you very much for joining us today for this webinar on COVID-19 and the crisis in India. The second wave of the virus has brought devastating effects to many regions of the country, with record cases of infection and a shattering death toll. According to official figures assembled by Johns Hopkins University, India is second only to the United States in case numbers, with more than 25 million confirmed cases and more than 250,000 deaths. In the last month alone, figures from Johns Hopkins indicate that 10 million cases and 100,000 deaths have occurred. The actual figures may be a great deal higher. Earlier in this month, Brown University's Dean of the School of Public Health, Ashish Jha, has suggested that 25,000 Indians may be dying per day. The Institute for Health Metrics and Evaluation at the University of Washington has projected the possibility of a total of 1.2 million deaths by the time we reach August. The scale of suffering is, in any case, immense. Stories of shortages of oxygen cylinders and hospital beds have been widely circulated, and images of funeral pyres give some sense of the extent of loss and grief. Today's discussion is an opportunity in Ireland to gain a more intimate sense of this terrible experience from contributors based in different parts of India, and to learn from various perspectives on the crisis, including the personal, the social, historical, medical, and political. My name is Daniel Carey, and I'm director of the Moore Institute for the Humanities and Social Studies at the National University of Ireland, Galway. I am also the Royal Irish Academy's Secretary for Humanities and Social Sciences. Today's event is jointly sponsored by these two organizations as a forum for discussion of a humanitarian crisis in which we all have a stake. Over 170 people have signed up to attend today. Again, thank you very much for joining us. The session forms part of two different series, one that's been run by the Moore Institute and another that's been run by the Royal Irish Academy, and recordings of previous sessions are available on these organizations' respective websites. I'm very grateful to David Kelly for running things behind the scenes in the Moore Institute, and to Jennifer Keneally in the Royal Irish Academy for help running this event. The diverse group of panelists joining us today draw on wide experience and professional backgrounds, and I will now introduce them alphabetically. Kanchana Mahadevan is professor in the Department of Philosophy, University of Mumbai. She teaches and researches in the areas of feminist philosophy, decolonization, critical theory, political thought, aesthetics, and film. Her book, Between Femininity and Feminism, Colonial and Post-Colonial Perspectives on Care, 2014, examines the relevance of Western feminist philosophy in the Indian context. She's currently working on the relationship between the secular and the post-secular from comparative and gendered perspectives. She's also examining populism and democracy from the perspective of comparative philosophy. In 2019, she was a visiting fellow in the Moore Institute at NUI Galway. Dr. Sanjay Nagral is director of the Department of Surgical Gastroenterology at Jaslok Hospital and Research Center in Mumbai. And he also heads the Department of General Surgery at the KV Baba Municipal General Hospital. He held fellowships at the King's College Hospital and the Royal Free Hospital in London from 1995 to 97. Among his many publications, he co-edited the book Healers or Predators? Healthcare Corruption in India, published by Oxford University Press in 2018. He was the Joint Secretary for the Zonal Transplant Coordination Committee based in Mumbai from 2012 to 2017. In addition to his work as publisher and member of the editorial board of the Indian Journal of Medical Ethics, he writes for a range of publications on issues of public health, medical ethics, and organ transplantation, including the Times of India, Indian Express, Hindustan Times, Mumbai, the British Medical Journal, Scroll, and Wire. Since last year, he's been writing a weekly column called Second Opinion for the Mumbai Mirror, Mumbai's largest circulating English language newspaper. Dr. Srinivas Raghavendran is lecturer in economics at the J.E. Cairns School of Business and Economics at NUI Galway. His current research focuses on several major themes in the areas of macroeconomics, finance, and political economy, appearing in a range of international journals. He has spoken at leading global events like the International Monetary Fund and the International Economic Forum of the Americas. He's been a visiting professor at Paris Panthéon-Sorbonne, La Sapienza University in Rome, Johannes Kepler University in Austria, and the Indian Institute of Science in Bangalore. In India, Raghav has served as an expert economist for the development priorities for Rajasthan and development priorities for Andhra Pradesh, projects as part of the, and this is part of the Indian prioritization project conducted by the Indian Consensus Center in New Delhi. Aveek Sen is a freelance writer, teacher, and collaborator with artists. He lives in Calcutta and works across the arts, literature, cinema, and music. He studied English literature at University College, Oxford, and worked as associate editor of the Telegraph, Calcutta. He was given the 2009 Infinity Award for writing on photography by the International Center for Photography in New York. Archana Venkatesh is assistant professor of history at Clemson University in the US. She's a graduate of The Ohio State University, and her research interests lie at the intersection of South Asian history, oral history, women's history, and history of medicine. She's currently working on a manuscript titled Women, Medicine, and Nation Building, the Lady Doctor and Development in 20th Century South India, which examines the role of women doctors in the creation and extension of development initiatives in South India from 1919 to 1970. Her research has been supported by the American Institute of Indian Studies. Thank you very much. Thanks very much to all of you for joining us today in such difficult circumstances. It's a really important, I think, moment to gather and to seek insight from you and your experience and outlook. Raghav, I'd like to start with you if I could. You're based in Madurai at the moment, and you've had obviously quite harrowing personal and family circumstances, but I wondered if you could tell us a little bit about what you've been observing and your thoughts on the crisis in India at the moment.
Well, in terms of where I am, I live in a state called Tamil Nadu in the southern part of India, and a city called Madurai. It's about 450 kilometers down south of Chennai, or Madras, what it used to be called. I'm in a rural part outside the city. At this point in time, my local locality or local village is about 12,000 people, which is on it's a red zone. So I can't go out anywhere. It's a total lockdown here. About 500, 600 cases every day in this area alone. And it's been quite very tough for the past a month or so in this, as Tamil Nadu started picking. The case numbers are rising, and death rate is also going up, fatality rates are going up. And a lot of people I see in the rural parts between Madurai city as well as in the rural areas that are not reporting, and so on and so forth. There's a lot of issues in terms of hospital beds, lack of availability of lack of beds, oxygen, and so on and so forth. What I observed, from say November to April this year, as case numbers came down in January, and there was a sense of triumphalism that began to emerge in India, and it was buttressed by a faith of unique Indianness or Indian exceptionalism. That actually got carried away in terms of both elections that happened in the 5 states, as well as the religious festivals that happen across India. Particularly, coverage was given to Kumbh Mela, which happened it happens every 12 years. It's for those who don't know about Kumbh Mela, it happens every 12 years. People take ritual dip in holy rivers of Ganges and so on in North India. That actually created a wave that happens from January to March, and Election Commission started this election preparations. And from November to January, November to April, they had a lead time in terms of preparing for this second wave or preparing for the future. But nothing of that sort happened. There was a National Executive Council which meets under this National Disaster Management Act, never met. You had temporary COVID facilities that were set up by central organizations that were lying largely empty since December, and they began to dismantle all that. Genome sequencing, proceeded at a leisure space. Nothing happened in terms of sequencing. 167 oxygen generating plants had been sanctioned after 2020 peak, but there was a little follow-up, and 32 had been set up till mid-April. Other things like banning exports of vaccine in end of March. No attempt was made to relook either at ramping of vaccine production or accelerating pace of vaccinations. There was a willful neglect of approaching second wave because of the leadership, central and state caught up with politics. And April 15th, we crossed about 200,000 new cases and doubling on 30th April and so on and so forth. I just want to leave with one general comment that I've been thinking about it on this, the whole episode, both the first wave and second wave. And, if one steps back from this grim situation that is unfolding, it is a fusion of two hegemonic political projects. One is the Hindutva based political ideology that constructs the nation state in terms of a pure singular identity, being an Indian, and seeks to establish an exclusivist majoritarian nation. The other one is the neoliberalism, a global project that proposes well-being be cast advanced by liberating individuals, with an institutional framework characterized by strong private property rights and so on. But critical to this fusion is the role of state, a reconfiguration of the role of state, particularly in Indian context. It is an Indian variant, as I would say, or Indian neoliberalism has taken a distinctive form with variations and contradictions as it interacts with, reinforces, and reshapes the underpinning social context of deep-rooted Brahminical patriarchy, a worldview, the structuring of the social order, which is based on upper caste purity and that places the lower caste and women in subservient positions. And this plays out all the time in all the issues and policies that we see over and over, whether it's lack of beds, lack of oxygen, lack of infrastructure, or in terms of rural areas, lack of other amenities and so on. It just plays out in terms of this. I would say the confluence of Indian liberalism, as I say, Hindutva liberalism, rooted in this patriarchy, actually is actually creating problem, not just today, for the future as well. That's my take on it so far.
Thank you very much. There's a lot to come back to there. I wanted to turn to Sanjay, if I might. Sanjay, you're working in the hospital system. You're a surgeon by training, but you're also commenting on medical affairs in India. So I wonder if you could talk to us about your experience in Mumbai or more widely.
Right. So I don't quite know where to begin, but of course everybody, most of the world now knows about the gory details of what's played out in India in the last year, and also now, especially in the last few months. And I think COVID affected many countries, but I think what's been peculiar to India is number one. Um, the complete lack of access to healthcare. We know COVID is a bad disease and COVID kills, but in the current wave, especially, we have had people dying because they could not get oxygen and could not get into hospital. So I think that's something that is uh, peculiar and very, very depressing. Having said that, anyone who works in Indian healthcare or knows Indian healthcare closely uh, would be very disappointed and depressed, but not be very surprised at the turn of events, uh, because we have a very dysfunctional healthcare system, um, which is strangely highly privatized, uh, but completely unregulated, and with very limited access for the large majority. And on the other hand, the public healthcare system is underfunded and in complete retreat over the last few years. And that in a way links to what Srinivas just said, that we have chosen to a path of, even in healthcare, a path of private development. But I think there are two or three other factors that played out in looking at to analyze the sheer severity of our problem. The first, of course, is that India has a very big system of traditional system of medicine, and we all, of course, respect that system. But what has happened is that every system of medicine in India claims its own treatment, its own cure for COVID, and that's completely muddled the situation. And science has never been our strength, and therefore what we have also seen is the use of lots of unproven therapies, some of them deadly therapies. So, for example, a lot of the problems that we're seeing now is due to the rampant use of steroids. And as all of you would know, steroids are very double-edged medicines, very double-edged drugs. So I think this has further worsened the situation. And finally, before I conclude, I just want to say that the peculiar situation, especially in the second wave, and what is perhaps unique is that the elite of India, who had sort of protected themselves from the ravages of daily disease and healthcare by creating this private healthcare system, have suddenly been exposed. People have died without beds, people have died without oxygen. And I think that is one reason why there is so much of an uproar. Uh, because the elite have been affected. And the Indian diaspora across the world is also very upset because their parents, their fathers, mothers, brothers, sisters are suffering and dying. So what has actually been a chronic problem over the years has suddenly burst out because there is huge, people who matter have been affected.
Thank you very much. Yeah, the distinctive nature of the medical care system is obviously a crucial consideration. And I suppose it speaks, as you were saying, to a point that Raghav was making about the neoliberal dimension of how the system works in an Indian context. There's also echoes of the United States in many of the things that you're saying, particularly in the somewhat fanciful cures that evidently become enacted in different sorts of ways. Kanchana, I wonder if I could turn to you now. And you're also based in Mumbai. You're a professor of philosophy. And how have you responded to the crisis? What do you think we should be thinking about in understanding the particular form it has taken in India? You're muted there. So.
Yeah, as a someone who is a teacher, as someone who is in the context of institutional teaching, I have noticed that this particular pandemic has, in a way, changed academic life because we went on to the online teaching mode. So we had a way of getting all our computers together, getting our homes organized, and letting everyone into our homes via the online digital mode such as Google Meet and Zoom and so forth. So in a way, what I noticed this pandemic has led to is a kind of a blurring of the public and the private domains. And on the positive side, it is in a way, I think the digital technology has helped us mediate. So that is very positive because when people were seeking help for oxygen cylinders and beds and so forth, people were volunteering on social media to help out with that. Vaccination appointments were being taken on computer apps, and social interaction itself has become online. So in some way, this is helping us cope with the grief, solve problems, be compassionate to one another. So I think in these respects, it all looks very good at one level. It reminds me of short novel by Rabindranath Tagore called Chaturanga. It had two characters, two brothers, Jagmohan and Harimohan. Harimohan is indifferent to the plague that ravages Calcutta because he is obsessed. He's a kind of a fundamentalist, obsessed with just turning to God for resolving issues. And Jagmohan is very literary. He has studied and read a lot of books, and he's very sensitive to the pain of others, but he ends up succumbing in the course of being compassionate. So I think that this online education, in a way, gives us a choice of not succumbing, but at the same time being compassionate and sharing the grief, partaking in the grief and so forth. But there is a very big issue. The one question we teachers keep asking students and students ask us is a question that Nell Noddings, the philosopher of care, has brought up as a very important question in pedagogy. So this has naturally emerged in my pedagogic context, at least in the course of teaching. What are you going through just now? So how are you doing? How is your connectivity? Is it working out, etc.? So and then are you able to give your assignments? No, because I can't give my assignments. I can't meet the deadlines because I've not had connectivity. I've not my smartphone broke down, and so forth. So one has to think beyond the rules orientation and the deadline orientation in academics to actually do the business of thinking and writing and working together. So I think in that sense, it has been a positive thing. But then Hari Mohan, the very sort of indifferent brother in Tagore's novel, haunts us because to what degree is this compassion really reaching out? This is a question I've been asking myself. We confront the digital divide. So there are enormous inequities, the kind of inequities that were brought out by the previous panelists based on caste, gender, class, and several of our students cannot afford, for example, to live in the city of Mumbai because we have a subsidized hostel that is not available during the pandemic. So they have to go to the rural areas. They don't get connectivity. They are not able to give their exams. There was a student who wrote when it is too late because that student was feeling too shy to tell us about the fact that she could not even afford a smartphone. So somewhere this digital technology is viewed as a private commodity, a neoliberal private commodity. So unless we treat it as a public good, something that is available to all, excuse me, something that is accessible to all, I think this problem is going to persist. And so if the caring, compassionate part of education has to be really taken ahead, I think one would have to convert a lot of the devices into freely available commodities for all, yeah, for genuine, equitable compassion. Yeah.
Thank you. Thank you. There are questions there we definitely want to come back to, and some of the points you've been making resonate in different ways in Ireland, of course. And there's been some attention to the digital divide, but not necessarily any particular solutions coming forward. Aveek, I wonder if I could come to you next. You're based in Kolkata, and I know this moment has affected you and your family closely. I wonder if you could share your observations on the pandemic and this second wave, as it's been referred to, of the crisis.
Yes, I'm going to keep my observations, Dan, quite micro and quite concrete and quite limited to the personal and the domestic, because in a way we are all leading domestic lives now. And I completely second Srinivas and Sanjay's larger economic, medical, political, social, sociological analysis of the situation. What I want to add to this is that I want to speak now as a teacher, and in that way I continue what Kanchana has begun to outline. I feel, I teach the liberal arts, humanities, the arts, the visual arts, cinema, and what is happening is that my students and the people that I'm interacting with are having to ask extremely radical, fundamental questions about the relevance of what they are reading and learning and making and regurgitating in their academic or creative lives in relation to their own bodies, the bodies of others, in relation to death and mortality, in relation to caregiving, and in relation to domestic work and labor. And this is making them ask questions to which, these questions themselves, important and vital and fundamental as they are actually leading to a crisis which I, as a teacher or even as a collaborator with artists, I can only live the questions. I cannot really resolve them. And I think this is an extremely important transformation in our relationship with what we do and how we think that is happening at an extremely bodily, concrete level. The other thing that is happening is that this this divide, this inequality, it's not something that is between us and them. It's right there in our homes. You know, I live with an elderly person who is invalid, and her attendant is the person who died in our household after suffering from COVID. And we realize while dealing with her illness and with her death, what the nitty-gritty of dealing both with the medical aspect of it and her family and with the afterlife of her death meant for someone from that class, that gender, that caste, meant to us, you know, we who are privileged, upper middle class people who are connected on the internet, and what it meant for us to actually confront her family, to give her the care that she needed, and to also to deal with our grief and to somehow make our grief for her a sort of a mere attendant in our household, somehow real and communicable to people like us, who would say, oh, well, okay, you all tested negative, so, you know, you're fine. So this is something that we have been brought, I mean, extremely closely in contact with, and we are still working this out psychologically, intellectually, critically. And I'm not even going into the political aspect of what it means for us as citizens and as persons to confront in our own lives what Srinivas and Sanjay have been outlining in macro terms. Perhaps in our Q&A, we can do that. So I've deliberately kept my, what I had to say to my own little sphere of life at home at the moment.
Thank you, Aveek. And I think you draw attention to one of the problems, which I think has been experienced at some level in a worldwide way, which is the intimacy of grief and loss against the backdrop of an enormous loss and the distorting effects of grief in that moment. So maybe that's something we can come back to and try to think our way through.
And the meaning of art, what does it mean to be an artist or a writer or a creative person or a poet in this kind of a time?
Yeah, that is a great question. I'm very interested in, so hopefully we'll have a chance to come back to that. Arch, if I could turn to you now, and you're based in the US, so you're in this difficult position of having family in India and trying to maintain those connections. I'm sure it must be particularly distressing, and you experience that distance, no doubt, in a much more acute fashion. But your research is also extremely interesting and I think relevant to the questions that we've been looking at. So I wonder if I could ask you to comment.
Yeah, absolutely. It has been, I will say, an incredibly difficult time to, you know, not be with my family or not see anyone in my family for what feels like, it has been years actually. But yeah, that was really fascinating. I was I mean, there's so many connections between what everyone else was saying. And I think as a historian who works on, you know, the history of the institutionalization of medicine in India, I wanted to talk a little bit about something that I've been reading and something that we've all been reading, I bet, about India in the past few weeks, which is this massive headline that says the system has failed, right? But here's the thing though, the system hasn't failed. It's done exactly what it's meant to do, which is not exist. One of the horrifying statistics that's come out in the wake of the second wave is that India invests, by some estimates, anywhere between 0.3 to 1.3% of its GDP into public health infrastructure, which, you know, in comparison to other countries in similar developmental stages is pretty poor, just numerically speaking. So one of the things that I wanted to understand is why is this investment so low, especially since privatization of healthcare didn't really take off until the 1980s with the rise of the Apollo group of medical hospitals, which are now the site of some amazing medical tourism, are being touted as, you know, whatever 7-star medical hospitals and all of that stuff that we keep reading about. And I wanted to go back a little bit to the British colonial policy making, which was really the roots of Indian developmental policy making with the 5-year plans, right? And the first time we see any kind of institutionalization of Western medicine in India is with the massive plague in the 1890s. And the way in which this was policed, loads of other things, but the thing that really struck me was this led to the rise of caste-based hospitals, right? So it already revealed the fractures and the hierarchies of which is what make up modern Indian society, which is caste hierarchies and, like Raghav said, Brahminical patriarchy. So the thing that Indian, well, mostly Hindu citizens objected, or subjects, I should say, objected to the most was being put in isolation wards with people of lower castes. So the way in which this medical developmental policy making was instituted was based on exclusions and divisions. This went on to inform the rise of, the welfare state model of healthcare provision, that is public healthcare, right, with the first 5-year plan in 1950. And a lot has been said about the first 5-year plans focused on industry and the industrialization. Nehru famously said, dams are the temples of modern India. That's what we should be working towards, building up industry. And there wasn't a lot of focus on healthcare. And when there was any kind of mention of developing healthcare for this massive population, it was folded in with other developmental goals, mostly family planning, which was something that was disseminated all over India, rural and urban, targeted at poor people and lower caste people by and large. So one of the reasons why privatization of healthcare was able to take a hold of the system so, well, a stranglehold really, was because of this lack of attention and lack of public funding when it comes to public healthcare systems. And I wanted to talk a little bit about privatization, which was, antithetical to the goals of this mixed economy that the Nehruvian development goals were trying to create. The founder of Apollo, Pratap Reddy, said that he had to go through the rings of fire of Indian bureaucracy to set up his hospitals, which are incredibly successful today and became even easier after after the liberalization in the 90s, as we talked about. But the thing that gets missed out in this picture is that private hospitals were not overwhelmed by the first wave of the COVID pandemic in India. That's not what happened. What's happening today is that private hospitals are being overwhelmed, which reveals exactly who's able to access these private hospitals. They're expensive. It is only those of upper middle class and upper classes who are able to access healthcare. And this shockingly means that most of the population has been affected by the first wave. That is, most of the migrant labor and the rural labor population. It's just that it wasn't reported on, and the people who were affected by the first wave are not able to access this fully funded 7-star medical care, right? I was actually thinking a lot about the whole welfare state model, right? We are so proud of our public distribution system and the National Rural Employment Guarantee Scheme. The thing that gets missed out is that migrant laborers who are from rural parts of India cannot access any of these benefits if they work in cities, which most of them do. I'm sure we all remember from the first wave this incredibly horrifying image of workers moving from Delhi to rural parts of Bihar and UP, where they were from, getting physically sprayed down by disinfectant, right? And the reason that they are moving to rural parts is because that's where they can access any kind of state support. So there's a lot of holes in the system, and it was designed that way. So the system hasn't failed. That's just what it's meant to do. And I wanted to end with something that I've also been thinking about, because India has a massive child immunization program, right? So it seemed optimistic to assume that our vaccine rollout would be possible, even streamlined. The thing that we've all seemed to have overlooked in that assumption is that India does not have an adult immunization program ready to go. It's limited to child vaccination programs. And I'll stop there.
And Arch, if I could ask you, is that particularly in relation to polio, or is it more generally with child immunization programs?
Sure, it's polio. It is also the BCG, like, measles, diphtheria, and the other thing that I've forgotten, but all of these vaccines that you get as a child.
Right. Yeah. So because there has been some attention drawn to that. Obviously, it's an issue we haven't talked about, is also vaccine production and pharma generally in India, which is so extraordinary. So there's some paradoxes. There's some very interesting and striking themes of continuity and experience in Europe, but also some very, very particular and distinctive disjunctions, I guess, if I can put it that way. So yeah, I guess we'll kind of have our sort of more general discussions. Everybody can kind of turn your cameras on, and we'll kind of reconvene, so to speak. Raghav, I might begin with you. There's a couple of questions that have come through, and one is asking about your thoughts on why the positive cases in the US are, in terms of numbers, are higher than in India, when the US didn't have the equivalent of Kumbh Mela or elections. I mean, I don't know if you feel especially comfortable in commenting on the US situation, but there are these paradoxes. I was thinking partly in relation to what Arch was saying about, so the US has an enormous investment in its healthcare system, and yet is still world leading in this tragic set of tables. So I don't know, Raghav, if you had any particular thoughts on the US.
I can just say that, you see, as Archana pointed out, we don't have that kind of infrastructure. 1% of GDP is what we spend on public health. And if you look at the out-of-pocket, health expenditure by individuals, it's out-of-pocket. 60% of the health expenditure is out-of-pocket expenditure of the total expenditure of individuals. So when I live in a rural part in Tamil Nadu, I speak to people before the lockdown and so on. They are afraid to go for testing, because the moment you go for testing, if you are, if you get the positive result, you're immediately picked by the, panchayat or the municipal corporation people, and then you're put in some hospital. You don't know. It could be public hospital. If you're public hospital, you're lucky, you don't pay. But then if you get into private hospitals, you're finished, because people have not, come out of their debt from the first wave, mind you. People are indebted from the first wave of the lockdown and so on. People have no money to pay, and these are not easy, simple sums that one is talking about. So when you talk about 1% GDP, even the economic survey of 2021 says, which government publishes, that if you increase your public health expenditure by 1% more, you will reduce the out-of-pocket expenditure by half. That will actually help. So people are not going forward, for testing. That could be one reason that you can see why.
Yeah, I think there must be an enormous number of contributing factors, but I think there's general agreement, at least in the commentary that I've read, that there is very serious underreporting, and that can be viewed in different ways, that there's something nefarious about the underreporting, but it can just be a structural issue, I think, in light of what's been said. That seems, intuitively to be the case.
Can I just add on to one more thing to that? In Tamil Nadu, particularly, I'm talking about Tamil Nadu rural areas, people do believe that, what Sanjay said about the Ayurvedic and the medicine, the concoctions that they have. There are 3 concoctions that are very famous in Tamil Nadu. In fact, government actually prescribes these concoctions. 9 herbal mix called Kabasura Kudinir. Then you have 15 herbal mix called Nilavembu Kudinir. This is, neem and so on, herbal. And there's the other one, arsenic alba. These are something that is prescribed by the government. people take it and they think that they got the immunity. They get the immunity and they don't think that they should go and test. So many people say, oh, I'm not feeling good. I'm going to have that Kabasura Kudinir or whatever that herbal mix is. And that's about it. I got the immunity. So they do believe of the traditional Indian medicine because you didn't have any medicine before in the first wave. So people were taking these concoctions and then that continues, right? So that is also a contributing factor for why people are not going for testing and they actually think that this actually works.
Right. Yeah. Sanjay, I wonder if I could ask you a little bit possibly about that, but I'm also interested in the phenomenon of regional variation in India. I mean, it is obviously a vast country, so that's probably not unexpected, but do you have any comment on the nature of that? Is that the way the healthcare system works, that certain regions have been more effective in their public health measures, or, can you help us think about that?
Yeah, so yes, India, some people would say, is actually many countries put together, and there is huge variation even in many other parameters, but certainly healthcare. I think if you study the reasons for the variation, it is probably linked to the way those states developed. Kerala is an example. Kerala is always the example, where you had high levels of literacy, you had actually a huge politicization of healthcare in the good sense of the term, and therefore people fought for healthcare. Tamil Nadu, incidentally, is one of the better healthcare systems. On the other hand, in North India, there are the states which always have lagged behind in healthcare. I just want to quickly take this opportunity to comment on what I think something that Archana raised, which is if when the British left us, they tried to suggest the NHS kind of model, because this is something that you will identify with in Ireland. And in the early days, actually, if you see all the policy documents in India, they actually all talk about universal healthcare, etc. But somewhere along the line, we moved away. One can blame it on many things. The why of it is still not very clear to everyone. But perhaps one thing is that, I've been thinking a lot about this. Why are we like this? And I think one of the things we must understand is that perhaps the dominant narrative in India is fate and destiny. So we are like this, and this is what is in store for us. And that fate and destiny is something which is very strong as a thought.
Yeah, well, that rings the bells in Ireland. I must say there's a cultural tradition of fatalism in Ireland, which is also part of the political culture in the sense that it lowers expectations. And it means that people have already, I hate to use the phrase priced in, but they've already anticipated disappointment and frustration. Other countries have very high expectations, and they becomes part of the political agitation in some sense. So perhaps that's part of the dynamic there. Kenshin, I wonder if I could ask you, this is an interesting comment that's come in from a colleague who works in public health, Ivan Perry in UCC, University College Cork. And Ivan makes an interesting comment about health and social justice being inseparable. I think it's quite a helpful way to put it, and partly because it really picks up on a point that I think has struck me, and I think has been helpful today, even in reinforcing, which is the sense that the COVID-19 crisis is really about the order of values. It is a health crisis and has to be understood in those terms, but it is also a crisis in the order of values. So do you find that you're, as a philosopher, as somebody who teaches philosophy, that's a subject you're bringing into the classroom? Are there opportunities to talk with your students about these kinds of questions?
Yeah, I do think that the question of social justice has to be linked to pedagogy, in this case, a caring pedagogy. So I have been working in the field of care ethics, and I've been thinking about how care ethics is very significant these days, because my students like coming to class. Several of them who would cut class during the face-to-face classes ended up coming to the online classes. And when I asked them, how come you come to the online classes, you never came to class last year when we were face-to-face, their point was that, we kind of prefer this because we are able to connect with the teacher better. We are able to speak our minds out, and it is more therapeutic. Primarily, of course, they're coming for the therapy part of it, because in the course of the grief, I have a student who lives in Dharavi, and he has no access to spaces, for connecting. And so he has to, there are about 8 people in a small room, and he has to sit in a corner with a mobile phone. But then in the process, he's able to chat, and he's able to articulate and connect with the rest of the world, which he cannot do because of the lockdown. So in that sense, it is a process of a kind of a therapeutic process, I think, the classroom. But then my worry is that this pedagogy, which was earlier restricted to it was very businesslike, and delivering goods and delivering assignments, delivering degrees. Things have gone haywire because we are not giving degrees on time. Assignments are not coming on time. So obviously, the other panelists have raised the question of health. So that is the backdrop against which this pedagogy takes place. So we can't really segregate things, and we need to look at things in a holistic way. My students find philosophy particularly valuable in the context of the pandemic, and they've been writing very good assignments and so forth, because they're able to think about their lives via. And in fact, one of the problems also is that everyone wants to connect everything to the pandemic, whatever they are doing, and that becomes a kind of a reductionism too. So it is hindering that education in the classic mode. I want to teach the Hume and the Locke and all that, and we want to see how can they speak to the pandemic. So somewhere there is an extraordinary emphasis on the contemporary, what is present. And I think it is here that turning to the history that Archana just brought up is very important, because when we think of someone like Pandita Ramabai or Savitribai Phule, they were women in the pandemic context who were in social reform, who were in politics, let's put it as politics, in the 19th and the early 20th century. And one of the big questions they raise at that time is precisely this whole problem of segregation, which has become so inherent in India. So my worry is that the segregation of caste that Archana has talked about, one of my colleagues is here, Professor Narayan is here. We often talk about it, that segregation, caste segregation, is playing itself out in the digital divide, because those without, who don't get access to smartphones, laptops to do their homework and so forth, are typically people from underprivileged castes. They're typically poor, because most people from underprivileged castes are poor. So it is the Brahminical patriarchy that is playing itself out in the domain of pedagogy and the digital divide, I think,
Thank you. Yeah, actually, I wanted to come to Aveek and to pursue a question that you raised about the place of art in this moment. I think there's been a struggle to maintain the relevance of art and to try to think it through. And there have been different definitions. Some have been that art is consoling and even distracting. So those are the slightly different phenomena. And others, the discourse of well-being, that the arts are somehow to contribute to our sense of either getting through, but a purpose and place in the world. Have you come across any definitions of art that you think at this moment of crisis that have been particularly persuasive to you? Or do you think we really are struggling to say, where is the center of human existence at this moment of disruption? You're muted there, Aveek. Yeah. Oh.
I think, Dan, we are struggling. And you see, the other thing that has come with the whole ideology of being an artist is solitude and being an individual and all of that, which has completely been broken down now, because now the making of art, caregiving, and working at home, being involved in doing things, in not having a studio space in which to run away to, or a classroom to run away to, or a study to sit and think in, because it's usually in the study that somebody is isolating. So you are in there. So these are extremely important questions about space, about our cohabitation with other human bodies, about mortalities. And the way I choose to deal with it is to actually stop calling art, and we just sit and we think in ways that are effective, critical, political, about life and about the immediate and about the mortal. And if out of that a certain transformation of sensibility happens, which then indirectly happens to remake you as a creator or a writer or as an artist, fine. If it stops you from being an artist for the rest of your life, that too is fine. I think the immediacy of the situation is such that we cannot really privilege a life choice like this anymore. And we are, as I'm speaking, things are happening,
Yeah, I guess my own impulse is to think of art and culture as the meaning-making domains of human experience, and that therefore should be resources within this moment. But it doesn't follow that it's an immediate translation, or even that making of meaning and a sense-making can take place in the moment itself. It may be retrospective. I think there are unquestionably a whole series of different kinds of political, social dislocations that are going to happen, and rethinking of the order of value. So maybe that's something we have to think of as a future project rather than one which is instantaneous and occurs in lockstep with the progression of the crisis itself. Arch, I wonder if I could ask you a question that's come in from our colleague Nata Dovere, who is thanking, by the way, all the speakers for their insightful comments. But this is one I thought you might want to comment on. She said, are we witnessing a classical process of pauperization and differentiation, ultimately a wiping out of the rural society? I know you have interest in rural India and rural society. Would you go as far as to say that? Do you think that these are really forces that might be as much as eradication going on, or is it more repeating of a familiar pattern in terms of the distinctive relationship that you were commenting on between urban and rural in India?
I mean, that's a question for a dystopia, isn't it? That's what's happening. I don't know that I would go so far, but of course, I think that there certainly is a difference in scale in terms of what's been happening historically in policy making for rural India and healthcare in rural India. Some of the things that have been coming out of, especially, Sanjay, I think you mentioned that Bihar and UP especially have been pretty chronically lagging when it comes to healthcare in rural parts of the states. I think we're seeing an intensification of that because the reporting that's coming out of that part of the country has been very much focused on the lack of communication in the past 2 months between, from the lines of hierarchy in terms of, state policy making for healthcare, from the, state level Ministry of Health to the local village panchayats, like local governing body that is responsible for distribution of, say, masks or PPE to individual healthcare workers who go into villages to do their work, right? Because not everyone can access a primary healthcare center even. So there are a trained cadre of ASHA workers who go into individual villages to raise consciousness and raise awareness about COVID and identify people with symptoms and, hopefully encourage them to isolate, although of course there's a lot of stigma associated with that, as Raghav pointed out. So I think that the thing that has changed in terms of what's happening to the rural in this wave is that this line of communication has completely broken down. That's what I'm reading from, people that I worked with in rural Tamil Nadu. And I haven't worked in rural Bihar, but that's what I've been reading from the reportage there. And I think that there is not just a lack of communication, but a lack of material distribution of any kind of protective gear for these ASHA workers whose duty it is to go into individual villages and identify COVID, people suffering from COVID-related symptoms.
Thank you. Yes, I had a question actually for Raghav, if I might. I suppose in Europe and in North America, there's such a focus on, you know, the order of values is structured by economic interests, which are set against, you know, the impulse of care and responsibility to lock down in favor of those who might be at risk and so on. I'm just picking up on what you're saying. Is that kind of economic discourse? I think it has a very different inflection in India. Is it part of the whole of what drives public conversation, or is it a different? Does it occupy a different space?
Well, it is part of you know, public conversation, but you know, public conversation to the extent that it can be accommodated in public. You know, the shift from I would point it's not just happened today, or it's been happening for some time. The shift away from a social citizenship based entitlements to a commodified market-based model of welfare. That actually is at the core of what is driving you know, the impacts both in rural areas as well as the urban areas that Sanjay talked about. The discourse that happens in economic circles and, you know, the public discourse on economy and so on, you know, this aspect comes, but this aspect is not actually in the limelight. It's not highlighted because, you know, many of these questions about the project that I talked about is a Hindutva neoliberal project. You know, it has an exclusionary, you know, angle to it. You know, it demolishes the solidarities of class or caste through the construction of, you know, gender, family, nation in their identities. And it has so many ramifications in so many realms. You know, it's in terms of population regulation, governance of populations, you know, move from welfare, as I said, social entitlement to welfare, commodified welfare model, as well as undermining labor rights through labor courts. Mind you that during this period, COVID, in the first wave, about 44 central labor courts were merged into 4 labor courts. That has massive implication for, you know, labor market itself, you know, the flexibility of labor market, and it's going to drive a lot of people very flexible and casualization that's going to happen. And the most hit in that is essentially women. These kind of discourse happen, but you don't have that kind of space that you have would have in other countries.
I'm conscious of time, and we're running close to our available hour. Sanjay, I wonder if I could come to you, since you're working in the medical system, the healthcare system. Do you have any projections about where you think things might be going? There's obviously is a vaccination program, and I've, you know, seen various statistics on the levels of vaccination. Are you are things slightly improving? Do you see, you know, the potential for rapid improvement, or are you more pessimistic about what might be happening over the next few weeks and months?
So there is some evidence in some parts of the country, especially Mumbai, that we are seeing a slow decrease in cases. But of course, the hospitals are still full, especially the intensive care units. Vaccination, as you know, we are running very slow. I think we are going to take a lot of time to reach that critical level of proportion of citizens to be vaccinated for it to make an impact on everyone. Predictions, well, I don't know. COVID has taught us not to make any predictions, and most predictions have not come out to be true. But one of the things that worries me, one thing is that we are seeing a lot of chronic illnesses. You know, there is something called long COVID, but we are beginning to see that, and how the healthcare system is going to cope with it. If there is indeed some cause for optimism and hope. It is in the fact that perhaps as never before, we are discussing health in India. Public memory is very short in India. So I don't know whether that translates necessarily into a sustained interest in health. But I can see that in the next few elections taking place in India, and health will certainly move up on the priority. And that's really the silver lining, if there is any.
Okay. We should draw to a close there. I just wanted to thank all of you very warmly for taking the time today. I've learned an enormous amount of the situation. I think there are many analogies with situations we've been experiencing in Ireland, points of solidarity and contact, areas where we can learn and exchange, I think, and create a more just and intelligent relationship to this ongoing crisis. So thank you very much on behalf of everybody attending today. I couldn't do justice to all the questions that came in. There were a great many different comments and things. Thank you to our audience for joining us today. So again, thank you very much.
Yeah, thank you, Dan. Thank you.
Bye-bye.